I know.
It's like you don't even care that the dogs aren't here.
Oh,
It's like you don't even care.
I miss them.
Around
I'll watch it. It's not even picture. I might be.
All right, good afternoon. Let's go ahead and get started. As you can see, we've got, well, I guess you can't see. We got a whole bunch of people joining us on Zoom today for all kinds of reasons. So this will be recorded and it'll be available through the Zoom tab in my courses if you want to go back and watch this again. So for a change, the lectures are actually ahead of the labs. I've already talked to you about what we're going to be doing in lab today. So in our previous lecture before break, I talked about some of the details of the dissection of the pharynx. You should have already looked at the posterior wall of the pharynx, the posterior musculature, like the three constrictor muscles and some of the other structures in the posterior view of the pharynx. But today, we're actually going to cut into the posterior wall of the pharynx and explore the inside of the pharynx. We're also today going to do the bisection of the head. So we're going to saw the head in half, almost in the midline. I may have mentioned this before, and I'll go over it again when I demonstrate the dissection today in lab. But we don't want to saw directly down the midline, because if you do that, you're going to completely destroy the nasal septum. What we want to try to do is saw just a few millimeters, either to the left or the right, doesn't matter which side, but just saw a few millimeters to one side of the midline, so that we'll preserve the nasal septum on one half of the bisected head, as well as the interior of the nasal cavity on the other side of the bisected head. So that's what we're going to be doing in lab today. On Monday, we're going to be doing this dissection, which is the larynx. So we'll be continuing to look into the pharynx from a posterior approach, and we'll be looking at the structures of the larynx from behind, so the structures of the voice box. So what you're seeing here is a picture of the skeletal structures that make up the sort of rigid framework of the larynx. Now, there's only one actual bone in this area, which is the hyoid bone. And if you look towards the top of the slide, you can see the hyoid shown in an anterior view. This is an anterior view of the structures of the larynx, which is actually, this is not the view that we're going to be looking at on Monday. We're going to be looking primarily at a posterior view of the larynx. So we'll get to that in a few minutes, but I just wanted to orient you to the different structures in this area. So as I started to say, the only bone in this area is the hyoid bone. And the hyoid bone has several distinctive features. The central part of the hyoid, which is the most anterior part, is known as the body of the hyoid. It then has two long projections that project posteriorly. These are known as the greater horns. And you should have already felt the tips of these greater horns as they project posteriorly, because they actually go all the way to the back of the larynx. And the tip of the greater horn of the hyoid is a good landmark for identifying the middle pharyngeal constrictor muscle. Once you've identified the middle constrictor, then you can move on and look at the other constrictor muscles. So those are the tips of the greater horn of the hyoid that extend all the way to the back of the pharynx. The hyoid bone also has these much smaller structures called lesser horns, which look like, I don't know, looks like a set of upside down vampire teeth to me. Remember those little wax vampire teeth you used to put in your mouth when you were a little kid? So think of that next time you look at a hyoid bone. Those little horns, those lesser horns, are the point of attachment for the stylohyoid muscle coming down from the styloid process. The hyoid bone is really not technically part of the larynx itself. It actually sits superior to the larynx. The larynx itself is formed from 4 different cartilages: the thyroid cartilage, the cricoid cartilage, and a pair of much smaller cartilages that we haven't seen yet called arytenoid cartilages. So you can see on this slide also the thyroid cartilage, again, in anterior view. Thyroid cartilage has a large body, which is the main part of the cartilage, makes up the whole anterior and lateral surfaces. Right in the very center of the body of the thyroid cartilage is something called the laryngeal prominence, all better known as the Adam's apple. So this is just a protrusion from the anterior surface of the thyroid cartilage. Similar to the hyoid bone, the thyroid cartilage also has greater horns and lesser horns. But you'll notice in the picture that the horns are oriented very differently. In the hyoid bone, the greater horns are projecting posteriorly towards the back of the pharynx. In the case of the thyroid cartilage, on the other hand, the greater horns are pointing superiorly up towards the hyoid bone. And in fact, the greater horns of the thyroid cartilage are connected to the hyoid bone by that membrane that you see there. It's not labeled here, but it's called the thyrohyoid membrane. The lesser horns of the thyroid cartilage project inferiorly and actually form a hinge joint with the cricoid cartilage. So if you look on either side of the thyroid cartilage, you look at those lesser horns that are extending inferiorly, you'll see that they form a sort of an attachment with the cricoid cartilage on both the left and right sides. And turns out that's a sort of a hinge joint or pivot joint. I'll show you this more clearly in a few minutes in a different picture, but the whole thyroid cartilage can tilt forward or backward at that hinge joint relative to the cricoid cartilage. So the cricoid cartilage itself is a complete ring. You can't tell that from this view, but it forms a complete circle going all the way around the entrance to the trachea. And it's often referred to as being the first tracheal ring, or kind of a modified tracheal ring. Then you see the remaining tracheal rings begin just inferior to the cricoid cartilage. There are some really important differences between the cricoid cartilage and the other tracheal rings, though. As I mentioned, the cricoid cartilage is a complete ring. So if you look at it from the top, it looks like a donut, forms a complete circle. Turns out that the tracheal rings, even though we call them rings, they are not complete rings. The tracheal rings don't form a complete circle. They form something that looks like a big letter C, and they have an opening at the back. And we'll see that in another view of these cartilages. You'll see that the posterior aspect of each tracheal ring is actually open and is filled in with just a fibrous membrane. So the tracheal rings are not true rings. They don't form complete circles. One other structure that's just barely visible here is the epiglottis. This is a flap of cartilage that sits posterior to the hyoid bone and posterior to the entrance into the larynx. We'll see that in just a minute, a little bit better view. So here are the same structures viewed in a lateral view. Again, starting up here with the hyoid bone, we've got the body of the hyoid bone, which sits most anteriorly. The small lesser horns, the little vampire teeth sticking up from the body of the hyoid, and then the greater horns extending posteriorly all the way around to the back of the pharynx. And again, just as a reminder, that's the origin for the middle pharyngeal constrictor muscle in the back of the pharynx. Here's that thyrohyoid membrane connecting the thyroid cartilage to the hyoid bone. And then here again, we see the thyroid cartilage. So most of the thyroid cartilage we call the body of the thyroid cartilage. It's got that laryngeal prominence or Adam's apple at its anterior tip, and you can see how that protrudes forward from the body of the cartilage. Greater horns extending superiorly towards the hyoid bone, lesser horns extending inferiorly and forming that little hinge joint or pivot joint with the cricoid cartilage. And then the tracheal rings sitting inferior to the cricoid cartilage. I think I may have forgotten to mention the arytenoid cartilages on the previous slide. They were just barely visible. Let me jump back to that. The arytenoid cartilage are just barely visible here because they're shown ghosted or transparently. They actually sit posterior to the thyroid cartilage. So we'll get a better view of them in some of the other views. Here in this lateral view, you see just a teeny little bit of that arytenoid cartilage kind of peeking out from behind the thyroid cartilage. So now we take a posterior view, and you'll finally get a better view of those arytenoid cartilages here. So once again, starting up at the top, we've got the hyoid bone. Now the opening of the hyoid bone, that sort of U-shaped or horseshoe-shaped opening of the hyoid bone is pointing back towards us. So the tips of the greater horns of the hyoid are facing posteriorly, as I said, to the back of the pharynx. And again, we've got that thyrohyoid membrane connecting the hyoid bone to the thyroid cartilage. The body of the thyroid cartilage is now sitting, anteriorly. And here we see the greater horns extending superiorly, lesser horns inferiorly, forming a joint with the cricoid cartilage. Here you see the back of the cricoid cartilage, and the posterior aspect of the cricoid cartilage is taller than the anterior part. The anterior part of the cricoid cartilage is a little shorter. The back part of it, the posterior part of it, extends higher up inside the thyroid cartilage. And you can see that the cricoid cartilage is completely solid at the back, as I said before, forming a complete ring, like a complete donut around the entrance to the trachea. But then if you look at the tracheal rings down here, you'll see that there's a gap at the back of the tracheal rings. They're more like a big letter C as opposed to a complete circle. And there's a fibrous membrane that fills in the opening of that big letter C. And now we finally get a better view of these arytenoid cartilages. I've always thought these things looked like little elf hats kind of perched on the back of the cricoid cartilage. They're not very firmly attached to the cricoid cartilage. They can rotate left and right. They can tilt, kind of rock back and forth. Like if you ever go bowling and you hit a bowling pin and you watch that bowling pin kind of wobble back and forth a little bit. I've always thought of it as being like that. So you can think of it as an elf hat or a little bowling pin, either way. But they can, as I say, they can tilt forward and backward. They can tilt medial laterally, and they can actually rotate. So there's a lot of movement of these arytenoid cartilages. As we'll see in a few minutes, the arytenoid cartilages are the posterior attachment for the vocal cords. The anterior attachment for the vocal cords is the inside of the thyroid cartilage, specifically the inside or posterior surface of that laryngeal prominence. And one of the reasons that men typically have deeper voices than women is just because during puberty, one of the changes that occurs is that laryngeal prominence enlarges, which makes the vocal cords longer. And just like with a guitar string or a piano string or something like that, the longer it is, the lower the frequency of its vibration, so the lower the pitch of the voice. So the posterior end of the vocal cords is attaching to the tips of these arytenoid cartilages. The anterior end would be attaching to the inside of the thyroid cartilage, right on either side of the epiglottis. You also finally get a better view of the epiglottis in this view. It's just this flap of cartilage, kind of reminds me of like a leaf or something, and has a very minimal attachment to the thyroid cartilage. It is attached, but it's not much of an attachment. So that epiglottis is it's attached by a lot of musculature, and it's covered with a layer of mucous membrane, but the actual cartilage attachment to the thyroid cartilage is pretty small. So we're going to be approaching the larynx from this angle primarily. I think the dissector on Monday may have you look at the anterior surface a little bit, put the head back in normal anatomic position, look at the front of the thyroid cartilages just to identify all these things again. But our primary dissection is going to be from the back. So you'll be looking at these cartilages from behind. But the cartilages are not going to look exactly like this because they are covered with layers of musculature and layers of mucosa or mucous membranes. So this is much closer to what you're going to see when you dissect into the larynx from behind. So on the far left and far right of this image, what you're seeing here are the constrictor muscles of the pharynx, the pharyngeal constrictor muscles that have been cut and reflected open as a couple of big flaps. That you're going to do today. You're going to be doing a vertical incision through all of the pharyngeal constrictor muscles, all the way from the base of the skull, all the way down to the beginning of the esophagus. And you're going to fold open those big flaps of pharyngeal constrictor muscles. And you're going to look inside. Today, you're going to be looking inside the nasopharynx, which is way up above where this slide is cut off. So looking into the nasal cavity from behind. You'll be looking into the oropharynx, looking at the back of the tongue. You'll see the epiglottis today, and you'll see the entrance to the larynx today. But a lot of this other dissection down here, we're actually going to do Monday, so you won't see a lot of this stuff today. So in this particular view, as I said, we've opened up the posterior pharyngeal constrictor muscles, and we're now looking into an area known as the laryngopharynx, the part of the pharynx or the throat that lies behind the larynx. And the larynx is enclosed within these cartilages here. You can see the back of the cricoid cartilage identified right here with these muscles sitting on it. The arytenoid cartilages are kind of hidden by some muscles here. And the epiglottis is covered with a layer of mucosa, so it no longer looks like that sort of leaf shape. And all of this is going to be covered with a layer of mucous membranes. And what you're going to do on Monday is you're going to begin stripping off the mucosa off of the posterior surface of all these structures, exposing the different cartilages and some of these muscles that you see here. So let's walk through some of what we're looking at here. So again, we've got the epiglottis here, that little flap of cartilage, but in this case, completely covered with mucous membranes. We have the entrance down into the larynx. So this is basically branching off of the pharynx, branching off of the anterior aspect of the pharynx to enter, the other pipe, so to speak. You got the esophagus here, but that's the entrance to the larynx, which then ultimately, becomes the entrance to the trachea. This opening to the larynx, it's not labeled here, but sometimes it's referred to as the aditus, A-D-I-T-U-S. Just a fancy word for the opening into the larynx. You can see the posterior edge of the thyroid cartilage on the left and right. You can just probably make out where the greater horn of the thyroid cartilage is here on the left, and also on the right over there. Lesser horns are kind of hidden, but they'd be forming a joint with the cricoid cartilage. And you see the cricoid here right in the midline. And then some muscles. Probably the most prominent muscle that you're going to see, that you'll see most clearly, is this muscle called the posterior cricoarytenoid muscle. And I just realized it's misspelled. It should be arytenoid muscle. There should be an N in there between the E and the O, cricoarytenoid muscle. That muscle is probably about an inch long, and should be pretty visible as soon as you strip the mucosa off of the posterior surface of these structures. We'll talk more about that muscle in just a minute and get a better view of it. There are also some thin muscle fibers that are kind of crisscrossing back here behind the arytenoid cartilages. They're simply labeled arytenoid muscles here, but there's a transverse arytenoid muscle, which are the horizontal fibers. And then there's an oblique arytenoid muscle, which forms kind of an X posterior to the arytenoids. Let's jump ahead to the next slide. I think it's a little more obvious here in this next slide. So here we've zoomed in on the same structures. We've still got the epiglottis up here covered with mucosa, but now we can see a better view of the posterior structures of the larynx. And here's a better view of that posterior cricoarytenoid muscle. So as the name suggests, and it's actually spelled correctly here. As the name suggests, it's connecting the cricoid cartilage to the arytenoid cartilage. Turns out you have a couple of different cricoarytenoid muscles. This one's called posterior cricoarytenoid because it's originating from the posterior aspect of the cricoid cartilage. We'll see in probably the next slide that there's also a lateral cricoarytenoid that lies more anteriorly and laterally. It's kind of hidden from view here, but it would be originating on the cricoid cartilage in more of a lateral or anterior position. And both of these cricoarytenoid muscles are then connecting to the arytenoid cartilage, which sits right up here. You'll be able to see those attachments better in just a minute. And then, as I said, there are also these muscles that are simply called arytenoid muscles, or sometimes called arytenoideus muscles. There's the transverse arytenoid muscle, just fibers connecting the left arytenoid to the right arytenoid cartilage, just going, sitting in this horizontal plane. And then you have these oblique arytenoid muscles that originate from one arytenoid, kind of cross to the other side, but they actually extend all the way up to the epiglottis itself. And these muscles help to pull down on the epiglottis. When you swallow food, you want the food to bypass the larynx and continue down into the esophagus. You, of course, don't want food to go down into that additus, into that opening to the larynx. So there are really two things that prevent food from going down into the larynx. One we'll see in a little bit. There are some folds of mucosa actually inside the larynx. They're actually called false vocal folds or false vocal cords because they look like vocal cords, but they're not. They're not responsible for giving you your voice or sound. These false vocal folds come together and close off the entrance to the larynx. So that's one thing to prevent food from going in there. But the other thing is pulling this very flexible epiglottis down so that it essentially covers the opening to the larynx. And these oblique arytenoid muscles are partly responsible for pulling that flap of cartilage down to seal off that opening. All right, you probably won't be able to get this particular view in dissection, but it's a helpful view to be able to see the orientation of some of the different muscles in the larynx. So a couple that I've already mentioned. Here's that posterior cricoarytenoid originating from the posterior aspect of the cricoid cartilage and inserting on a little protuberance or a little projection on the arytenoid cartilage right there where I'm circling with the cursor. And then the lateral cricoarytenoid muscle originating from the lateral surface of the cricoid cartilage and inserting on that same little tubercle, same little protuberance of the arytenoid cartilages. And you might be able to tell from this picture that when these muscles contract, they're going to move that little tubercle of the arytenoid in two different directions. So the posterior cricoarytenoid is going to pull that little tubercle one way. The lateral cricoarytenoid is going to pull that little tubercle the other way. And these muscles both control rotational movements of the two arytenoid cartilages. Here's the transverse arytenoid muscles again, connecting the left and right arytenoid cartilages, and then the oblique arytenoids extending up to the epiglottis. A couple of other muscles that are visible here that we couldn't see in the previous view. And these are going to be pretty difficult to see in your dissection because we're probably not going to break off half of the thyroid cartilage and look at the larynx from this point of view. These are kind of hard to see from the posterior dissection that we're going to be doing, but they're worth mentioning. One of these muscles you may not remember this, but you've already learned it. There's a muscle here called the cricothyroid. It's originating from the cricoid cartilage here anteriorly, and it's cut off, so you can't really see where it's connecting. But if you try to envision those fibers continuing up towards the thyroid cartilage, they would have their insertion actually on the inside of the thyroid cartilage up in this area where I'm circling with the cursor right now. Those cricothyroid muscles, we saw them when we were doing the anterior dissection of the neck, but we didn't really talk about them very much. We didn't really talk about what they do. When those muscles contract, they actually pull the thyroid cartilage anteriorly. So they originate from the front of the cricoid, they insert kind of laterally and almost posteriorly on the thyroid cartilage back in this area. So when those muscles contract, they actually rotate the thyroid cartilage in an anterior direction. You remember just a few minutes ago, I was talking about the fact that the lesser horn of the thyroid cartilage, jump back to that here. The lesser horn of the thyroid cartilage forms a joint with the cricoid cartilage. That cricothyroid muscle originates here on the cricoid cartilage and attaches to the inside of the thyroid cartilage up here in the body. When that muscle contracts, it causes the whole thyroid cartilage to rotate or tilt forward. And it's doing that motion at that joint between the lesser horn and the cricoid cartilage. So that's a little pivot joint, allows the whole thyroid cartilage to tilt forward at that joint. That actually has the effect of tightening up the vocal cords to increase the pitch of the voice. Another muscle here that's going to be a little tricky to see, but it's worth understanding what it does. It's a muscle here called the thyroarytenoid muscle, and that connects the inside of the thyroid cartilage near that laryngeal prominence to the arytenoid cartilages posteriorly. When that muscle contracts, it does just the opposite of what the cricothyroid does. Whereas cricothyroid causes the whole thyroid cartilage to tilt forward, when this muscle contracts, it pulls the thyroid cartilage posteriorly, causing the whole thyroid cartilage to tilt back, tilt posteriorly. When that happens, that causes the vocal cords to relax. It reduces the tension on the vocal cords. All right, one final view of these cartilages and some of the muscles is a superior view. And you're not really going to be able to see this either. We're not going to really be able to look down into the larynx, but if you were able to look down into the larynx with all of the mucosa removed, because all of this would be covered with mucous membranes, you can see some of these muscles from a little bit different orientation, and I think maybe be able to appreciate some of their movements a little bit better. So again, here's the posterior cricoarytenoid muscle originating from the back of the cricoid cartilage. Posterior is at the top of the slide, anterior is at the bottom. So posterior cricoarytenoid muscles originating from the back of the cricoid cartilage and attaching to that little tuberosity or little protuberance here on the arytenoid. So you might be able to imagine that when that posterior cricoarytenoid muscle contracts, it's going to pull that little tubercle there in a medial direction. But it turns out the arytenoid has kind of a pivot point, or like a hinge in the middle of it. When you pull this little tubercle medially, the opposite end of the arytenoid cartilage over here is going the other way. So pulling that tubercle medially actually causes the front of the arytenoid cartilage to rotate laterally. We would call that abduction of the vocal cords, because the vocal cord sits right here. connecting the arytenoid cartilage to the inside of the thyroid cartilage. So when the arytenoid cartilage rotates laterally away from the midline, it's opening up the vocal cords or abducting them, moving them away from the midline. Now, under what circumstances do you think you would want to open up the vocal cords, abduct them so they're not touching? Probably not singing, because in order to make any sound, they need to be touching. And you need to push air between them to cause them to vibrate. Eating? Probably not. Now, the vocal cords themselves don't prevent food from going down into the trachea. There's a set of other folds just above them called false vocal folds or false vocal cords. But in order to eat something, if you don't want it to go into your larynx, you actually have to bring the false vocal cords together. You have to close them. You certainly don't want to open them if you're eating. So it'd be kind of the opposite. How about just breathing? Yeah. If you just want to breathe, you just want to, air in and out, you open up the vocal cords. You're not trying to make any sound. You're not trying to sing. You're not trying to talk. You just want to allow air to flow easily up and down through the larynx and, through the trachea. So you abduct the vocal cords to just allow air to pass through without any kind of obstruction. Over here laterally, we have the lateral cricoarytenoid muscles. And they're originating from the sides of the cricoid cartilage. They attach to that same little tubercle on the arytenoid. When they contract, they're going to pull that little tubercle kind of laterally and anteriorly a little bit. But remember, there's a little sort of hinge in the arytenoid here. So if you pull that little tubercle laterally or anteriorly, it's going to cause the rest of the arytenoid cartilage to rotate medially, which would be to adduct the vocal cords, to bring them together so they meet in the midline. And so now, why would we want to do that? Why would we want our vocal cords to touch? To make sound, to sing, to speak, make any kind of noise. In order to produce any kind of noise, you have to force air through the vocal cords while they're actually touching. And as the air is forced between them, it then causes them to vibrate, which is what gives you your voice. Yeah. I'm sorry? The highest decibel level that a human can make? Wow. I don't know. Bill Brewer is right up there. He's got, the grads have no idea what I'm talking about, but all the undergrads have taken anatomy and physiology with Bill Brewer, and he has this, he's like 6'7". He has this incredibly booming voice, but I have no idea what the loudest human voice is in terms of decibels. It's an interesting question. Likewise, I don't really have a good idea for what the range of frequencies is either. Like the lowest pitch voice. I mean, I can't get very low, and I definitely can't get high. So what's the highest frequencies? Don't really know. Yeah.
So the lateral muscle rotates the cartilage laterally.
Well, it pulls
It
pulls the little tubercle laterally, but that causes the rest of it to rotate. And actually, there's a better picture of this here, where I put little colored arrows on top of everything. So the pink arrows represent the movements of the lateral cricoarytenoid. The muscle is pulling anteriorly, causes that little tubercle to rotate laterally and anteriorly, but the little black dot represents the hinge point. So everything anterior to that little hinge point then rotates in a medial direction. to bring the vocal cords together towards the midline, to adduct the vocal cords. And on the left side over here, we got some green arrows showing the action of the posterior cricoarytenoid. So the posterior cricoarytenoid is going to pull that little tubercle in a medial direction, but that causes the other side of the arytenoid to rotate laterally away from the midline. So that would be abduction of the vocal cords if you just want to breathe. So the two cricoarytenoid muscles, the posterior and lateral one, they're primarily responsible for simply opening and closing the vocal cords. If you want to just breathe, you want them open. If you want to make noise, you want them closed. Something I didn't mention on here, but other muscles that assist the lateral cricoarytenoids with adduction include these transverse fibers of the arytenoid muscle sitting back here. They're not labeled on here, but with the cursor, I'm kind of going back and forth over the transverse part of the arytenoid muscle. That literally just pulls the left and right arytenoid cartilages closer together. It just pulls them together, which also helps to adduct or close the vocal cords. There are also two muscles, I've mentioned them before. We're looking at a little different view here. Two muscles that control the pitch of the voice or the frequency of the voice. This muscle over here with the blue arrows on it, that is the cricothyroid. So that's originating from the anterior or lateral part of the cricoid cartilage and inserting on the inside of the body of the thyroid cartilage. And when that muscle contracts, it's going to pull in the direction of the blue arrows. But the effect of that is it's going to tilt the whole thyroid cartilage anteriorly, again shown by the blue arrows over here. So that's going to stretch the vocal cords, put them under more tension. And if anybody, plays guitar or violin or any kind of stringed instrument, you've got those little tuning nuts, little tuning keys. When you tighten the string, you increase the frequency or the pitch of the vibrations. So by pulling on the vocal cords and stretching them tight, that's how you increase the pitch of your voice. The muscle that does just the opposite of that is the thyroarytenoid. And there's even a little muscle adjacent to that called the vocalis, which actually connects directly to the vocal cord. When the thyroarytenoid muscles contract, they are pulling the thyroid cartilage posteriorly. So the thyroid cartilage tilts back. And that relaxes the tension on the vocal cords, which is then going to decrease the pitch of the voice. It's like loosening up that guitar string or that violin string. All right, so you'll see some of these muscles, some of them you'll have a harder time. You'll definitely see posterior cricoarytenoid. You should see the arytenoid muscles that connect the two cartilages. You're going to try to peek in along the side of the larynx and maybe see lateral cricoarytenoid, but a lot of these others you won't really actually be able to see. But it's kind of interesting to understand, what they do, how they control the pitch of the voice. Oh, by the way, one thing I forgot to mention was the innervation of all of these. The cricothyroid is innervated by a branch of the vagus called the external laryngeal nerve, which came up in the previous unit of the class, although I don't think anybody actually identified it. It's a very tiny little nerve, really hard to find. So I don't know that we actually found it on any of the cadavers. But it's external laryngeal nerve, which is a branch of the vagus. That's controlling cricothyroid. All of these other muscles that I just mentioned, so posterior cricoarytenoid, lateral cricoarytenoid, thyroarytenoid, arytenoideus, transverse and oblique, fibers vocalis. All of these other muscles are innervated by a different branch of the vagus nerve. It's a branch known as the recurrent laryngeal nerve. Recurrent laryngeal nerve is a really interesting nerve. We'll see it better when we dissect the thorax. It branches off of the vagus way down in the thorax. I don't know if you recall this, but the vagus nerve gets its name from the same word or the same Latin root where we get the word vagrant or vagabond, meaning a wanderer. The vagus nerve innervates a lot of stuff in the head and in the neck, but then it continues all the way down into the thorax and eventually even down into the abdomen. This recurrent laryngeal nerve branches off of the vagus down in the thorax. On the left side, it then loops around the aortic arch and then travels all the way back up the neck, up into the larynx. On the right side of the body, it loops around the brachiocephalic artery and then travels all the way back up to the larynx, up here in the neck. So recurrent laryngeal nerve follows this kind of weird course, that it branches off way down in the thorax and then comes all the way back up into the neck. That word recurrent, you've seen that a couple of times before. Remember, there were all those recurrent arteries around the elbow. They were all bringing blood from the forearm back up towards the elbow. There was a recurrent branch of the median nerve here in the hand that was branching off in the median nerve in the hand and then coming back up towards the thenar muscles at the base of the thumb. So anytime we see that word recurrent, it kind of means like turning around and going back. So that recurrent laryngeal nerve branches off the vagus way down here in the thorax and then turns around, comes all the way back up in the neck, into the larynx to innervate all of these laryngeal muscles, except for cricothyroid. Cricothyroid innervated by a different branch of vagus. Right, so last thing you're going to do on Monday is you're going to actually cut into the interior of the larynx. Not a whole lot to see in there, but it is kind of cool to actually see the vocal cords. What you're going to do is you're going to make a vertical incision through the cricoid cartilage. And that's what's shown here. The cricoid cartilage has actually been split in the midline posteriorly here and stretched open. There's a couple little hooks that are shown down here, pulling the cricoid cartilage open to look into the interior of the larynx. The arytenoid cartilages would be sitting off to the sides here. As you pull the cricoid open, the arytenoids kind of move with it. So you're able to actually look into the interior of the larynx from behind. So just to kind of orient you, once again, there's the back of the tongue up at the top, the epiglottis covered with mucosa. The arytenoids would be kind of reflected off to the left and the right here. And then this is all cricoid cartilage down here. And if you look closely here, you'll see that there are two distinct sets of folds separated by a small space. And you should be able to see this in the cadaver. The lower set of folds are known as the true vocal folds or true vocal cords. These are the things that actually come together and move apart in order to, give you your voice, in order to speak or to sing. Just a little bit above them, maybe just a few millimeters superior to the true vocal folds, are a set of vestibular folds, also known as false vocal folds or false vocal cords. I guess they call them this because they look like the vocal cords, but they're false in the sense that these do not actually give you your voice. Instead, the false vocal folds, their only job is to close off the entrance to the larynx to help prevent food from going down into the trachea. Those two different sets of folds are separated by this little space called the laryngeal ventricle. And on Monday, when we do this dissection, you should be able to take the tip of a probe and kind of probe into that little ventricle. That's all I have for you today. It's a pretty short lecture and should be a relatively short dissection on Monday. Then we've got just a little bit more to do in the head and neck before we move into the thorax next week. Any questions about anything since we have lots of time? If not, use the time to get some lunch, take a nap, whatever you need. All right, and those of you on Zoom, I will see you later if I can figure out how to stop sharing here.
They look so